Yep. So, hi everyone. Thank you so much for signing up to our seminar today with Dr. Kotecha on the topic of returning to work after a respiratory injury. So, during the presentation, the attendees will be muted to avoid any random noises that might distract the presenter. If you have any questions, please pop them in the chat box below, and we will attend to them at the end during the Q&A session. So today we have Dr. Kotecha, who is a respiratory, sleep, and lung transplant physician based at Alfred Health. She holds an MBBS with first-class honors from Monash University and is a fellow of the Royal Australasian College of Physicians. So with over a decade of experience, Dr. Kotecha has developed extensive expertise in managing complex respiratory conditions, including cystic fibrosis, sleep disorders, and lung transplant care. So over to you, Dr. Kotecha.
Thanks very much, Sophia. I just want to make sure that everyone can see the slides there. Please let me know, if you can.
Yeah.
Beautiful, great. So thanks, Sophia, for the invitation to speak today. So Sophia and the MAG team have asked me to talk about returning to work after respiratory injury. And I guess the thing to preface this is that, respiratory injuries are often a little bit different in terms of how you quantify them. Say if you, from more of a physical injury, say if you, hurt your knee or hurt your shoulder or hurt your arm. So I think thinking about how you return to work in that situation can be a little bit different, particularly because the impact of that and the nature of the work that people do that often leads to their work-related respiratory injuries, and the implications of returning to work in that instance can be quite complex and challenging. So trying to tease that out is really, really important. So this is the outline. So I'll just briefly talk about the respiratory injury definitions, and we'll just touch on a few common work-related respiratory conditions that that I often get referred, and what their impact on work capacity can be. Looking at the medical investigations and reports that we use to assess the injury as well as capacity, some frameworks when we talk about how do we return to work, and some of the things we think about in return to work plans, which I think is really, really important when we come up with these plans for workers to be able to return to work. And then I guess I would just brief how when we get these IME or assessments to do, things that are really, really helpful for us to have in the when we get these referrals, and what to ask for and what to send, just to make the process more effective and streamlined and efficient for everyone involved, both workers, yourselves, and the medical specialists who are involved making the assessments. And I'll touch on some case studies if we've got some time at the end. So what is a respiratory injury? It's really any damage to the airways or the lungs. So airway starts, anywhere from here up the top, at the top of the airway, from your nose, your mouth, all the way down from your windpipe, all the way down to your lungs. And that can be caused by inhalation or exposure of toxic chemicals, fumes, irritants, smoke, or due to direct mechanical trauma as well. So crush injuries on the chest, rib fractures, pneumothorax, so collapse of the lungs, and the impact of that. And the symptoms and severity can vary, and they can vary based on even the same sort of lung function, the same injury between individuals, because how people perceive, just like people perceive pain differently from if you've had a knee injury or a shoulder injury, people can perceive their symptoms of breathlessness quite differently. So the main common symptoms when we look at people who've got respiratory injuries are feeling short of breath, cough and wheeze, so noisy breathing, or even stridor, so which is your upper airway, which is can be obstructed. And also that upper airway irritation, because as we talk about respiratory injuries, it involves from the upper airway, the nasal cavity as well. So you can get sore throat, blocked nose, itchy eyes, and headaches as well, particularly when you tend to get some of the inhalation injuries can cause systemic toxicity as well, particularly when we talk about carbon monoxide poisoning. I'll just close that one there. So they are very variable. And the ones that we often tend to see and get referred to are asthma or occupational asthma, which I'll touch on first up. The inhalational injuries, which can be sort of chemical, thermal, and systemic toxicities as well. Interstitial lung disease, which has become really more common, particularly in the advent of silicosis and silica-related lung disease. I think this is really our generation of asbestos-related lung disease. Asbestos was sort of, probably a couple of generations ago, which was cause of, occupational lung disease injury, and I think silicosis is the current one, and infection related as well, which I'll touch on. So what is asthma? So asthma is viral airflow obstruction, which is classically diagnosed on lung function testing, so spirometry, because you can't get the air out. And so the common symptoms are shortness of breath, cough, and wheeze, so that noisy breathing. And occupational asthma specifically is usually triggered by a toxic agent in the workplace. And classically, there's a real temporal relationship between the symptoms and their exposure. So often the symptoms get better. Their breathing and their cough and their wheeze gets better when they're away from the workplace. So if you often ask workers, they're often symptoms are terrible, during their working week, but on weekends or when they're not working or when they're on a period of holidays, their symptoms get a lot better. Now, treatment really is the avoidance of triggers, but if often the exposure is sustained consistently, over repeated long time, the asthma can actually become permanent. And even having time away from the workplace can actually still lead to persistent symptoms. And that's sort of different from this entity that's been identified called reactive airways dysfunction syndrome, which is a bit different to asthma because often there's no pre-existing illness or injury. Unlike asthma, where people can have underlying pre-existing asthma, and then that can be triggered or worsened by occupational exposures. But in reactive airways or RADS syndrome, it's often a non-immune response, and it's usually a single intense exposure to an irritant or a chemical or something that they get really big exposure to, and then they really find that really triggers things. We're moving on to thermal inhalation, so inhalational injuries. So as I mentioned before, there's really three main types. So thermal injuries, where you get damage to the upper airway or the main airways from heat, and they often get swelling and airway obstruction. So that can be quite dangerous, and that's a common thing often seen in firefighters, and it was a really big thing that we saw just, thinking about, the recent anniversary of September 11 and the, impact that we're seeing a lot of volunteer firefighters and firefights at the time. Chemical injuries, which are toxic gases and particles which cause inflammation and damage to the lower airways and the lung tissue. So that often tends to be less of an issue in the upper airways and more further down in the lungs themselves. And systemic toxicity, and the classic ones are carbon monoxide, and we don't see cyanide as much, but carbon monoxide, where you get absorption into the bloodstream, and that can cause real sort of effects, what we call systemic effects, so effects around the body. So it's that poisoning and toxicity, and the symptoms can be very variable. They can involve the upper airway, so you get what changes to your voice, your hoarse voice, which is often the first sign that you see that someone's voice changes when they get an inhalational thermal injury. They get difficulty breathing. They often say they're not breathless, but they're like, I just can't quite get my breath. They get a sore throat and a cough, and they often can get chest pain and noisy breathing. They often get stridor, so it's their upper airway because it's swelling and it's getting obstructed, and the airflow through the upper airway isn't smooth and it's turbulent, so you get that noisy breathing and wheeze. And they often get that confusion and dizziness. And the classic one that I've seen with carbon monoxide poisoning is people saying to me, I felt like I was hungover, like I've had too many drinks, but I haven't had a drink. They often get headaches and they feel really faint and dizziness, and then the confusion. Moving on to interstitial lung disease. So that's sort of inflammation and scarring and of the lung tissue. And it's usually due to inhalation of fine particles, so silica particles, asbestos particles, other particles, gases, vapors, and fibers. It's actually underreported, but now looking at the evidence at the moment, worldwide data, it's probably occupational related interstitial lung diseases probably accounts for 10 to 20% of all interstitial lung disease. And that's probably fast becoming the most common condition in major respiratory condition worldwide. Unfortunately, though, the disease burden is likely underappreciated because it's often under-recognized and it's underreported. And it's often difficult to attribute causation because a lot of the inhalation of fine particles, there's not a lot of evidence, or they're really rare causes of causing interstitial lung disease. So the common causes we know about are silica, asbestos, and coal dust, which we know here in Australia have become really, really common. We know we've got the dust board, the dust diseases, we've got, asbestos has been an issue, and silica and silicosis has been identified, particularly with the advent of engineered stone. And we'll all know, those of us here who are in Victoria, where I'm based, know that there's a big Now, luckily last year, the Victorian government has now, enacted a ban where there's no banning engineered stone bench tops because of the devastating impact that has caused in people, in stonemasons and stoneworkers. Less common causes are beryllium, which is just not seen as more, but that's a really common product that's used in aerospace equipment, electronics. Other hard metals, quartz dust, sandstone mine workers, denim sandblasters. And a lot of this data comes from places like India and Turkey, where we don't have, where we don't see that sort of work being done here in Australia as much. I guess infection related. So viral infections and transmission we contracted at work. And I think COVID-19 really taught us this, that people contracting COVID and the impact at work because of, and not having adequate PPE. And me as a health worker here in Victoria, here in Melbourne, which was the COVID capital, knew firsthand just what the impact of that had been, and the issues around, having PPE and the exposure to COVID. So the common ones that we tend to see are influenza, respiratory syncytial viral, RSV, and COVID-19. Now, by most accounts, usually these symptoms are self-limiting and patients get better, but rarely this can lead to persistent people feeling short of breath, and also bronchiolitis obliterans, where you get permanent scarring and narrowing of the small airways, leading to persistent respiratory limitation. So it is a rare but identified common condition due to respiratory viruses. So when we think about, what the medical investigations and the reports that we, me as medical specialists, when we assess respiratory, work-related respiratory illnesses, we really think about that temporal link between their exposure and the development or worsening of symptoms, the improvement from work, and other non-work related triggers as well. So looking at other exposures outside work, particularly smoking, both cigarettes, other inhalational exposures, marijuana, other recreational inhalational drugs, any non-work triggers, any underlying asthma, any underlying lung disease they may have just due to, and getting that temporal relationship and investigations that maybe predate their exposure. I look at their baseline oxygenation, what if they've got any examination findings. Often there's none. Their exposure data, so their personal sampling, whether they've got any sample, the monitoring of the area, any risk assessments that have been undertaken, such as mold reports or hygiene reports, HVAC logs as well, about what the ventilation, assessment and upkeep has been of the areas that are worked in. Patients have most commonly, all of them have had a chest X-ray, which is often normal, but can give some baseline information or some clues about significant lung injury with some scarring, particularly in those who've got interstitial lung disease. The CT scans of their chest is usually where the money is in terms of significant interstitial lung disease patterns. If they've got any gas trapping, in people who've got asthma or any obstructive airways disease, often asthma, though it's still quite normal. Any nodules suggesting they've had a previous mold exposure and they've been left with particular scars related to that, or any small airways disease as well in the setting of asthma. And getting their lung function, and if they've had serial lung function, so it's all well and good they do a lung function if they come and see me, but what's their lung function been that's predated, their exposure, but also over time as well. And looking at whether they've got obstruction, which is more in keeping with asthma, or whether they've got a restrictive defect on their lung function, which is more in keeping with interstitial lung disease. If they have some reversibility on their lung function, which again is keeping with asthma, but not all asthma demonstrates reversibility on baseline spirometry, and getting their diffusing capacity, so DLCO, also look at how the lungs actually handle the transfer of oxygen. And that's really important, particularly in patients who've got interstitial lung disease, is really important. Sometimes the lung function doesn't give you all the information, and doing serial peak flows, when they're at work versus not at work, is really important because it shows us the objective variability in their lung function, which is really, really important when we look at occupational asthma. And FeNO as well, which again shows us their variability. And sometimes to demonstrate that they do have what we call hyper-responsive, so their airways just tend to react more than the normal person to exposures, we do challenge tests as well with methacholine and mannitol. But by and large, when they come to us, they often have had their baseline lung function. And if we think that we need to pursue this further, we can then pursue having these more detailed lung function testing done. And I think that's all really, really important. So we do get a full and complete picture on what it is that their respiratory injury is and how we can correlate that with the severity of what we see on their CT scans, their lung function, with their symptoms to make an assessment about their respiratory injury, but also about how we then take this into account when we look at their fitness and their ability to return to work and in what capacity. So, as I mentioned, it's really sometimes quite complex and challenging, and really is an individual case by case basis on the nature of the injury, the severity of the respiratory injury, and the nature of the work that the worker is returning to, and what is being done to be able to facilitate that return to work. It really is injury and disease specific. And the issue is that sometimes the severity of their capacity of the worker can vary day by day. So you can have a worker who's got the same lung function, but because they're, if they've got asthma, for example, one day their symptoms might be, and their asthma might be really well controlled, and one day it's not. And so their capacity can really vary day by day, which makes returning to work and a plan to returning to work quite complex and challenging. The symptoms can be exposure dependent, but also exposure independent. So there are factors outside work as well that can impact their symptoms. And we've got to take that into account when we look at their return to work. And the dose of their exposure does matter. So when sometimes there are periods where there's a high or a peak dose exposure, and sometimes it's that intense peak exposure can be really challenging versus low dose but cumulative exposure. And that's really important to take into account as well. And in respiratory conditions, when it's sort of like, your fitness, so to speak, they often can become quite deconditioned, particularly in some of the occupations that our workers with respiratory conditions return to, which do require a significant amount of is quite physical jobs. And so if they become deconditioned because they're not used to doing it because they've been off work for a while, they've got deconditioning, which then can also impact their ability to return to work. And also, not forgetting the psychosocial overlay about sometimes the anxiety and the hesitation and the fear that can be about returning to work. So really taking that into account, as when we look at their return to work is really, really important. So I guess I'm coming at it from a WorkSafe Victoria point of view because that's where I've been to, so looking at the framework, so helping to employees return to work after illness or stay at work even during their recovery period. And, we're all aware that employers must consult and provide suitable employment for up to 52 weeks. And coming up with a really robust return to work plan with documentation is really, really important. And it's one of the hallmarks of the likelihood of a worker be able to return to work successfully. So being really clear in the duties that they're going to be performing, the hours they're going to be, doing, and the exposures that they're going to, be exposed to, and what controls are in place and who controls that and who assesses that is going to be really, really important. And also reviewing the plan, with a designated frequency. So it's not just a set and forget plan and not look at it again, but really reviewing it at a specific time point. So I often say early review, with a review to actually of the plan is really, really important. Looking at the controls to make the return to work safe, obviously in hierarchy, if you can eliminate and substitute the exposures, that's good, but really making sure if we've looked at any low volatile organic concentration of compounds is really important. Task relocation, so can this task be done in a different way or in a different location to make it the exposure, minimize the exposure or eliminate it? I've put in brackets there, wet methods. So prior to the ban coming in for engineered stone bed shunts, we looked at wet cutting methods because wet cutting was supposed to be better than dry cutting to have less silica exposure. However, it's still been demonstrated that even with wet method cutting of engineered stone, that there was still this exposure. So that's less of an issue now for engineered stone, but it may be that it's still a possibility for other exposures. Looking at the engineering controls, I think is really, really important rather than just sort of resorting straight to PPI. So looking at the local, the exhaust ventilation, looking at isolation method, we looked about HVAC logs and looking at HVAC remediation. Have we looked, and that's why keeping logs for that is really important. Negative air, ventilation is really important, sort of negative air pressure, to see if you can move air away to reduce the exposure. So those engineering controls, not just for that worker, but for other potential workers, is really, really important. Looking at the administrative burden, administrative controls that we can put in place. So rotating the tasks so they still can complete their job, avoiding peak exposure periods, and hot work permits. So, we know that sometimes we need hot work permits to do some work which are in high heat conditions, which can have an impact on workers. So looking at that is really, really important. And really being really mindful of the PPE and the respiratory protection standards and fit testing for the devices. So, having fit tests done for P3 masks is really important. And looking at the wear time limit. So how long a worker can wear that for comfortably and safely is really important. And therefore incorporate it when we look at the return to work plan and the timings that they can do that. And really using respiratory protection is the last line, not the plan. So we really need to go through the elimination, engineering, administrative issues before we resort to just using PPE. Now, a common question I often get asked as a respiratory physician is looking at workers return to work and if they've got a respiratory injury, their fitness for respirators. It's often a medical question. Now, most patients, the cardiorespiratory load, so we talk about the loads that people undergo when they're wearing a mask, is actually quite normal in most people with respiratory injuries to return to work. And there isn't what we call a hypercapnia risk because they're not a rebreather, because the worry is that you're breathing out, but if the carbon dioxide get out, you're just breathing back in. And that's really not an issue. But I will say that people often find, and anyone who's worn an N95 mask, I know myself, I have during COVID times, and I still do on a respiratory ward when I work in the healthcare setting, it actually does feel uncomfortable, and your breathing does feel a bit more laboured. So that subjective feeling of my breathing is feeling worse has a significant impact on workers, particularly if they've already had a respiratory injury. And there is a definite psychosocial overlay that can't be dismissed. So it's really mindful that we take that on board when we look at the duration of time people wear this and making sure they do have adequate breaks. Doing fit tests is really, really important. And we talk about having fit tests, particularly with facial hair for male workers, and they're fit to make sure that is undertaken on a regular basis. So the minimum is every 12 months is really what is thought to be appropriate. But often if people have had significant changes, for example, if they've lost weight or gained weight, having their fit test done again is actually really, really important. And the other thing to consider with wearing respirators here is anyone with skin conditions, sometimes then wearing respirators for a long time can cause eczema and skin irritation. And also the communication demands. If they're wearing a mask, they're wearing a respirator, can they communicate effectively and safely to their co-workers? And is communication, part of some of the safety precautions when we talk about work? So having, return to work plan includes the type of mask they wear. So I've showed a P2 here, which is the Trident mask, which is the one that I wear when I'm on the respiratory ward. Also the P3 masks as well, which is the major respirators, which are often used in the occupational setting also. The max wear time they can wear, any break schedule, and any trigger for a medical review is really, really important to incorporate in the plan. So building a return to work plan, we've got to think about, what the goals are. So the duties aligned with the capacity of the worker and the exposures, the duties and the hours where there's a graded progression, and having hold points. So, if I'm helping come up with a return to work plan, I look at when's a hold point. Is it a symptom-based hold point, which I think there should always be a symptom-based hold point? Is there a time-based hold point? There should be a bit of both, so that there are different mechanisms in place to look at the progression and making sure there are enough safety checkpoints so that we don't have, if there are relapses, what we do. Exposure controls, who does what and by when, and who is managing and reviewing those control exposures. Monitoring, so, asking returning workers who are returning to work, having symptoms log, monitoring their peak flows at work and keeping peak flow logs is really important to help looking at their gradual progression, and reviewing the frequency of that. So having early review. So I often, in most depending on the cases, will often put a review in for at least 2 and 4 weeks, but earlier if there have been any worsening of symptoms. And looking at how we escalate if we need to review the symptoms or review the plan earlier about if there's a relapse in their symptoms or relapse in their worsening of their lung function. Are there any pause and reset steps, and what else things we need to think about when we review this? And I think it's really, really important that this is, I mean, coming at it from a WorkSafe Victoria point of view, but this is a Safe Work Australia, initiative that we really do want to have a strategy that we do have improving return to work for workers so they can return to work successfully and stay at work, which is, what we're all after here. And so finally, I just wanted to touch on the, what our medical experts need. So a full job task analysis and getting even photos and videos of what the actual worker's doing, because, I'm a respiratory physician, I've got some occupational exposures, but I don't know every job that everyone's done. And sometimes when workers come to me and they explain their work to me, often the vocabulary doesn't align. And so I find myself wanting to understand in great detail their duties. And often videos and photos often provide a lot more information than, say a written or a verbal narrative. Exposure data. So often when the worker comes with their personal exposure, they've got photos, any photos of the area, any HVAC reports, any mold or occupational hygiene assessments have been undertaken with photos are really, really helpful for me to understand, particularly when it comes to mold and the degree of contamination, the amount of spores. That's really helpful to understand exactly what the exposures and the issues have been. Any incident reports that have been filed, but any near miss reports as well are really, really important. Just because an injury has happened this instance, but no one else has, doesn't mean to say there haven't been near misses. And it's good to identify that for us, when we help come up with return to work plans, but also for the safety of other workers in that same workplace. Any supervisor logs about any remediation or any steps they've put in place to keep their team safe. And obviously any certificates of capacity that have been provided to the worker. Prior medical records, and often, getting those early and being able to provide them to your medical expert early so we can put everything together even prior to us seeing the worker is really, really important, because it just makes everything more effective, and we can get really more detailed information when we've already got some baseline medical information about the workers. And obviously any other medical assessments that have been undertaken by the same specialty or any relevant specialties, the CT chest reports, even images. I love looking at imaging because I often then can find things and, I'm looking at it from a different angle than, say, the radiologist who's reported the CT is really, really important. And obviously lung function, any serial testing have been done. And obviously, if we get the medical, we obviously get this information when we assess the worker, but any smoking or atopy or any respiratory exposures, all that information is really, really helpful to allow your medical experts to make the best informed decision they can. So I'm going to move on to just a couple of cases that I just wanted to highlight. These are cases that I've sort of worked through and had. So the things that I like to think about. So a police complex with a mold exposure. And it was really clear that there was a real temporal relationship to the mold exposure because the symptoms flared on site and became normal between exposures. However, because there was repeated persistent exposure, subsequently the symptoms became more constant and more severe with minimal relief on days off. Interestingly, in this situation, there was an interim transfer to another complex because of backfill, and there was a significant improvement in symptoms. And then we found that the CT scan and a lung function that was performed was actually normal, but it was performed when the worker had then been transferred to the other complex. So there was no ongoing residual permanent damage, but we did have that the mold and hygiene assessments undertaken at that first police complex, which demonstrated very high contamination with visual evidence as well. And the symptoms were very consistent and with the temporal relationship with the exposure. So it was allowed to be that there was a real likelihood that that was the cause of the symptoms. And there was a plan in place to remediate the water ingress, which there was evidence of. There was relocation to unaffected areas. And there was a further mold and hygiene assessment undertaken post-remediation works. And there was some monitoring of serial peak flows as well, which demonstrated that after return to work, when the remediation works had been done, there was no symptoms and there was no change in airflow obstruction on peak flows. And secondly, here's a welder with a cough and shortness of breath with some fume exposure. A CT and lung CT was done, which said no significant gas trapping and no real scarring or suggestion of interstitial lung disease. The lung function was normal, but there was, a clear history of exposure assessments which were consistent with the welder symptoms. And the controls that were looked at were the local exhaust ventilation to capture and remove the airborne contaminants that came from the welding fumes, P3 respiratory protection with brakes, and a switch to low fume consumables, which I appreciate isn't always possible, but it was certainly explored and enacted in this case. And there was a return to work with some bench work first rather than returning straight to the welding. No high fumes tasks until the controls had been verified, which they had been. And then a step up at 2 and 4 weeks, so returning from the bench work to short periods of welding with the ventilator, with the respiratory protection, and a symptom log. And those reviews were undertaken, and it was a really successful return to work. So I hope I've highlighted there. Lastly, so the pitfalls. And I think when we're talking about returning to work, avoiding vague restrictions, like if I just say in my report, I'll just avoid the irritants, it's really, really hard for anyone to be able to enact that effectively, and what that means for the worker, what that means for the employer. So really converting to measurable limits. And you saw from those last 2 cases there about actually having specific, plans in place about restrictions and what to avoid and how to eliminate or control the exposures is really, really important. How do you measure that as well? I think overlaying on PPE and just saying, oh, just wear PPE all the time, well, that's not feasible and sustainable as well for workers. So you're really pushing the engineering substitution first, not only for that worker, for other workers, because then employers are actually setting themselves up for success for helping that person to return to work, but any other workers that may undergo similar issues and injuries is really, really important. And not having, if you don't have a relapse plan, so being able to make sure that just because you say this person returns to work and they have issues again, how do you make sure that you can roll back, and pull back and go, hang on, do we need to revisit the controls, the eliminations, look at their gradual exposure is important, and having holds in place to be able for the workers and the employers to be able to review that really, really carefully, which allows better success to return to work longer term. And really not making sure you don't skip on the fit testing, and making sure that workers can tolerate it from a respiratory point of view, but also from a skin irritation point of view, and making sure you do that assessment is really, really important. So I hope I've highlighted there, there's a lot of issues and factors that come into play when we look at returning to work after respiratory injury, both from the symptom, disease-specific point of view, the severity of symptoms, but also the nature of the work. And so it's really hard as a one-size-fits-all for everyone, but really looking at the specific nature of the work, what the exposure is, what the issues are, and how we can come up with return to work plans with good documentation and really clear guidelines for everyone, so that everyone's on the same page about what needs to happen to be allowed to workers to return to work successfully and stay at work. So that's been a lot of me talking. I'm going to stop there and stop sharing, and happy to take any questions and any issues you'd like to raise. So thanks. Over to you, Sophia.
Yeah, thank you, Dr. Kotecha, for a very informative presentation. So the Q&A session is now open. If anyone has any questions, just please pop them in the chat box and then we will attend to them. But I'll start with a few questions that I got from our case managers. So I know that it depends on the case, but what would you say is it like the average time for a person to return to work after these injuries? If like for a mild case, for example.
Yeah, so I think a mild case, I'll probably still say anywhere from, look, I'm guessing, but I'd say someone who had, I'll give you that example, that mold exposure. So that first, the police complex mold exposure. So they had symptoms, but then those symptoms would go away when they were away from work. So if they don't have persistent symptoms in between, and you've got good evidence they don't have any residual permanent damage, if they've been away from the workplace and the exposure is being controlled, there's no reason why they couldn't go back to work within a couple of weeks. Similarly, if they've had, persistent symptoms and I think you could review it within sort of 2 to 4 weeks even. Another one I've got is someone who had a carbon monoxide poisoning exposure. They sort of felt unwell for, sort of work for 48, 72 hours. And they felt completely back to a normal, the investigations they had showed no residual deficit. So really after 4 or 5 days, when they felt back to normal and there was no ongoing concern about exposure, they were safe to return to work. So it really is very disease specific. So I think someone who's got occupational asthma and asthma symptoms that persist in between, I think it can take longer because we really need to establish if we've got good control of the asthma has got well controlled, what their peak flows are and what their symptoms are like. And that can take anywhere from weeks to longer. I think interstitial lung disease, so anyone who's got, particularly someone who's got, for example, silicosis, I think that's a really different ball game because obviously anyone's got silicosis depends on the severity of their disease, but also what kind of nature of work they're going to be returning to. Because if they've got respiratory impairment based on their lung function results, their CT scans, and they do a fairly physical job, it's very, very challenging to put a time frame as to when they can return to work, but also in what capacity. So they may never be able to return to their same sort of physical nature of work. And it might require a retrain. So how we support them in that is really, really important. So it's very, very disease specific.
Yep. Thank you so much. And also there's another question is that I know that you listed out, what the case manager should be sending to you, but what would you want the case managers to avoid sending and how far back with the medical records that you want it to be?
Yeah, it's a really, really good question because often I get everything. I often get like hundreds and hundreds of pages, and often I get nothing and I get 2 pages and it's only the work claim and the certificate of capacity. I would say it's hard to know, but if you've got any medical relevant respiratory investigations that precede the symptoms and precede the exposure, it's really helpful because then you've often got a baseline to work with. So, the classic is for example, the weld exposure the person I had some pre-employment medical assessments done, which was great. And that doesn't always happen. But if they've got baseline lung function and CT scans, then I've got something to compare it to when they've had their test done. Because then it's often a question of, well, now they've got this lung impairment on their lung function on the CT scan. But how do I know? But they've often been a smoker as well, or they've got other exposures. How do I know this? And how much can I apportion to this exposure? And it's really, really helpful to know. And look, often you get a good sense of that from the history of from the patient, but we all know that it's very subjective. So I think it's very helpful that if you do have any objective assessments like lung function testing, like any imaging, but prior to their exposure and their work and their on this onset of injury, it makes attributing causation and apportionment a lot more straightforward.
Yeah, thank you. And we got another question from Adriana, who's an attendee. So the question is, I imagine there may be many variables with this question, but do you have any additional comments or advice for supporting return to work post-long COVID, please? Thank you.
Yeah, that's a really, really good question. I had a third case talking about long COVID, but I ran out of time because I thought I would allow it more time. It's a really, really good question, Adriana, and it's really, really challenging. I think assessing what their degree of symptomatology is post-COVID and what their symptomatology is, because a lot of patients with long COVID don't just have respiratory symptoms. They've often got other symptoms as well, like it's more like a chronic fatigue. And I think getting a sort of baseline assessment of where they're at and what their respiratory impairment is, and that's probably where I can comment more about their respiratory impairment. So getting their lung function and, for example, any physical rehab they've done from a respiratory pulmonary rehab point of view is really, really helpful to know and be able to see what their functional status is, but also about what the nature of their job is. Do they need rest breaks? So I think there's a lot of factors in play, and I think it often relates to the nature of their impairment post long COVID, because it's not always just respiratory. One of the common symptom that patients often with long COVID have is heart palpitations and chest pain. And that can be really, really difficult to quantify and attribute how much of that is an impairment on their of their ability to return to work. But it's a great question, and I think it's still an ongoing moving target as to how we assess that more effectively.
Yeah, thank you so much. That answer was really good. Yeah, so Adriana said, thank you so much. And
Pleasure.
I think that yeah, so our seminar, I think we can end here. But thank you so much for doing this with us, Dr. Kotecha. And thank you everyone who joins for the live session today. So yeah, thank
Thank you,
you.
Sophia. Thank you, everyone. Have a lovely afternoon.